All right. We're going to get started here just in a few minutes. Apparently, the link that went out via email was an incorrect Zoom link. So we're waiting for the email to be resent out. And so it'll take just a few minutes. They're sending it out as we speak so we don't get people that miss out as well too. So we'll get started here in like 2 to 3 minutes so we can let other people filter in as well too. And then we've got somebody that made it to the other side, Mr. Song. We're super excited. I see you. We are super excited to hear your story here shortly as well too. And then we're going to get into endocrine emergencies as well too. We're going to pick up where Nurse Brittany left off, where I was last week, where I was out of town last week, and we're going to start off with mixed edema coma because I want to clarify that a little bit of a harder topic, but it's starting to come up on the boards, and I don't really cover that. So I want you to have a little bit of reinforcement with that. We're going to get into Addisonian crisis. We're going to do a bow tie. We're going to do a case study. We're going to do some regular questions. So we got a really, really good and brand new lecture that I've never done before, that we haven't, questions that we haven't seen before. So get excited. We're going to start here in a couple minutes. So just bear with us as people trickle in. All right, let's go ahead and get started. And first things first, let's talk to somebody who made it to the other side. So let's find Nurse Bisong, and I hope I said that correctly. Nurse Bisong, did I say that correctly?
Yeah, Dr. Z. Perfect.
Oh, perfect. Awesome. I always butcher names, so I'm glad that I was able to pronounce that correctly. So Nurse Bisong,
Yes.
congrats. Welcome to the other side. What of NCLEX high yield did you use?
Dr. Z and you world.
I say look, less is more. You know, if you focus on just the program, if you focus on everything that we've created and that we're providing for you and use it with the Q Bank, and that's all you really need. It's very simple. Don't overdo it. So, with that said, what of exactly of NCLEX high yield did you use?
I registered the on-demand
Okay,
since June. I was in the class of May, June
May, June. Okay,
22.
2022. Okay,
That's my journey.
yeah. So,
Listen, folks, it's real. I can't believe I'm sitting here on the other side. It is real.
no,
Since
absolutely.
since 2022, I have not paid for no study material. Everything is free.
That was how it was in 2022. It's no longer like that now. In 2022, there was a until you pass. Now it's a guaranteed pass. So the guaranteed pass I'll talk about a little bit later. But yeah, it's a little bit different now in 2025 and 2024. Things have changed in the company. But nonetheless, you were able to use the on demand, even though you were in the live course, you used the on demand, you were able to pass. What
I
attempt
was
was,
on the live course.
yeah, in the
I
live course
used
in the
it.
Meijing.
Yes,
Yeah.
yes.
Yeah. And so what attempt was this for you?
Huh. I can't remember.
That it was
Honestly, Dr. Z, you're the bomb.
thank you.
Mwah.
I love it.
I need to see you physically. I just need that hug.
Absolutely. I love it when
It's
I run to
been
students in person.
it's been a journey.
Yes, absolutely.
First of all, I'm a foreign trained.
Right.
I think I graduated nursing in nine, 1989.
Oh, wow.
Yes, I did my midwifery. I completed the 2002.
Okay.
I moved to the US. I went through all the struggles. I wrote the NCLEX the first time, I failed. I wrote the LPN, I passed. So then, since 2007,
Mm-hmm.
I've been working like an LPN.
Oh, okay.
So I don't know how many times, might be more than 10 times.
Okay.
I can't remember.
Well, you know what? Look, 10 times first time. My record that I've had somebody come to me was 49 times. A pass is a pass. Yeah, 49 times is a true story. 49 times somebody came to me and said, I failed 49 times. I've been out of school for 30 plus years. So yes, it doesn't matter how many times you are on the other side. You use
Yes,
you use UWorld and you used and
Dr. Z.
that's it, Dr. Z and
That's
UWorld.
it.
That's all I say. Use a QBank and use whatever I provided for you, and you will be
Yes.
just fine. So how many questions were you?
150.
150,
Yes.
85, 150, anywhere in between. A pass is a pass is a pass is a pass.
Yes.
And now you get to wear that badge that says RN. Congrats. Congrats. Nurse Bisong,
God
thank
is
you
great.
so much. And
Dr. Z.
hopefully I do get a chance to give you that hug in person, okay?
Nezina. No,
Narzina
Nez
is
Brittany.
awesome. Nurse Brittany is
Nez
awesome.
Brittany. Thank
Yep.
you so very much.
Absolutely.
Keep
Absolutely.
doing what you're doing, Dr. Z. Thank you so much. All the questions of last Wednesday, I had everything.
Oh, wow. Endocrine was big on your test then.
I had everything. What do they call it? Psych.
It's like mental health. Yeah, Narzina. Yeah.
Mental health was like everything.
Wow, that's amazing. Well, that's always
Like,
good to know that everything that we're providing you is
yes,
giving you enough to pass your exam. So
yes.
that makes me very excited. It makes me
Thank
very
you.
proud of my team. It
Thank
makes me
you.
very proud of
Thank
you.
you.
So congrats, Nurse Bisong.
Thank you.
Thank you.
Thank you.
So a couple of things that I want to kind of touch on with Nurse Bisong's testimony. So first and foremost, it doesn't matter how many times you've taken the exam. As long as you go in and you take that exam and you pass it, a license is a license. Nobody's going to ask you how many times you took it. Nobody cares where you graduated from. The minute they see your badge, whether it says RN or PN, be proud of those two letters. Be proud of the hard work that you've put in from getting into nursing school to graduating nursing school to getting licensed. It's a process, it's a journey, and you all are meant for this. So just stay positive throughout the entire process. Very, very important takeaway. The other thing is, it doesn't matter how many questions you have. It doesn't even matter what you got on your exam, what your friends got on the exam, what you had on your last exam. We prepare you well enough in every subject and every system to pass this exam, as was just shown in Nurse Bisong's wonderful testimony. So, with that said, a few announcements before we get started into some very, very high yield endocrine emergencies that I'm going to compound from last week that Nurse Brittany did. So, first things first, remember all our QR codes, financial assistance letter, tutoring. We got Nurse Crystal, one of our newest team members. Nurse Crystal, you want to say a quick hello while I'm talking in the chat to everyone. Financial assistance letter, tutoring, free resources, our self-paced course, and our March live course as well too. March live course is going to be predominantly me teaching. We are limiting it to a certain amount of people. So if you are interested in the March live course, we are capping it because I'm using this course in March to replace all our on-demand with some new subjects, new updated notes, new updated material, and me teaching everything and updating everything. So we are capping it. So there's not going to be a lot of people in this course. So March live course, if you're interested as well too, it starts on the 15th. It goes to the 27th. The guaranteed pass. The guaranteed pass means I'm going to work with you to pass. Have I had people pass with the guaranteed pass? Absolutely. I guarantee your pass. Does that mean you can pay for it and get a guarantee? No. Just because you pay for it doesn't mean that you are eligible. I have to interview you. I need to make sure that I think you're able to pass this exam with my help and guarantee it. So it's not just because you spend the money that you're allowed to do it. I have to allow you to be able to enroll in it. So not everyone, I've denied people, those of you that are in here that I've denied, I apologize, but I've denied people that are not eligible for guaranteed pass on demand, available for 45 days, $299. If you're confused about your CPR report, I've been calling people. Nurse Brittany's been calling people. We're going through your CPR reports and going through them so we know exactly what's going on and how to guide you. And again, if you have questions, our entire admin team will reach out to you. And if it's a little bit beyond that, then myself and Nurse Brittany will pick up the phone and call you as well too. With that said, let's get started on endocrine emergencies. So you guys did DKA, cool. We did HHS, cool. We did thyroid storm, cool. And now I'm going to review mixed edema coma. So what is mixed edema coma? It is a severe form of hypothyroidism. But let's break down the words, okay? Mixed edema coma. Mix, actually, if you look this up, it's kind of a mucousy or slimy. That's what mixed means. A prefix that means mucousy, slimy. Edema is what? We know it's fluid. So it's a thick, slimy fluid. Now, in a case of severe hypothyroidism, we're worried about, and if you think about it, let's just do a little bit of thought process. Mixed edema coma, severe form of hypothyroidism. In severe form of hypothyroidism, do you think our cellular function is normal? Our fluid and electrolyte balance is normal? No, it's not. And it's severely hindered, which means that my normal fluid that would be throughout my body in every organ, in every artery, in every vein, is going to now become this mucousy, slimy, thick fluid because this is a form of severe hypothyroidism, which means everything is going to be affected. Everything is going to be affected. So now, things like post-thyroidectomy. Am I making thyroid hormone? No. Severe Hashimoto's. Am I making enough thyroid hormone to keep my body regulated? No, I'm not. So now I developed this severe form of hypothyroidism, which is, in fact, mixed edema coma. So the mnemonic is, and I know you went over this last week, but those of you that are joining for the first time, by the way, who is joining for the first time? Put it into the chat. I'm actually kind of curious. Mixed edema coma, hypothyroidism, mental decline. Well, yeah, you think if I'm severely if I have a severe form of hypothyroidism, is my brain going to be working properly? No. But it's not just, oh, I feel tired, fatigued, depressed. That's hypothyroidism. This is a severe form of it. Take it to the next level. Now I'm talking about coma, confusion. Which one of Ask Graph am I worried about with mixed edema coma right off the bat? I'll take two right off the bat, and one is more important than the other. So this is, in fact, altered mental status. Good. Altered mental status of Ask Graph. But the one that's more important than that is, in fact, airway. But we're worried about both in this situation. because my respiratory system is now severely suppressed. My mental acuity has severely been affected. My cold intolerance is severely affected. Extreme cold intolerance, hypothermia, edema. We talked about this. Is my fluid and electrolytes going to be normal? No, absolutely not. I'm not going to be able to get rid of fluid because what organ is not working up to its potential? The kidneys, the heart, everything's slowed down. So I'm bradycardic, I'm hypotensive. So am I going to be able to pump out that warm, red, oxygenated blood? Go back to what I teach on day 1 of the course. Think about that. That warm, red, oxygenated blood, if I'm severely if I have a severe form of hypothyroidism, then I am going to slow everything down, which means I'm not going to be able to get rid of that fluid. I'm not going to be able to perfuse my kidneys. I'm going to become edematous. Dry skin, dry hair as well too. So mixed edema, great little mnemonic right there as well too. We will put that into a quick tip and post it on all our social media platforms. So what are we going to do? Who knows what this means? There you go. Give them what they don't have. It's such a simple concept. Give them what they don't have. Those of you that are my students, you hear me say this repetitively. Give them what they don't have. Well, what are they severely lacking? They're lacking thyroid hormone. Give it to them. In this situation, we are concerned about their airway. Airway, airway, airway. If we're not having our thyroid hormone, which controls our entire metabolism, our entire metabolic pathways, then our adrenals are not getting what they need. So of course we're going to have adrenal insufficiency, and they're going to be cold, severely hypothermic. So passive warm blankets, we're not going to rapidly warm them. We're not going to throw them into shock. We open up those vessels too fast, we throw them into shock. We talked about shock, 2 weeks ago with myself, right? So that becomes that hypovolemic shock or cardiogenic shock. I would take actually either one of them. But now we get into adrenal crisis. Adrenal crisis meaning, or also known as Addisonian crisis. Well, we've got 2 parts of the adrenals, basic anatomy, okay? We've got the cortex and we've got the medulla. And I used to call it the medulla because it reminded me that it was in the middle. But in the cortex, there are 3 layers. And we always say the deeper you get, the sweeter it gets. So I go salt, sugar, and sex. So salt is controlled by what? In the adrenals, what controls salt in general? Aldosterone. Sugar in this situation is going to be controlled by cortisol. And then sex hormones are test and estrogen. Test and estrogen. In adrenal crisis or Addisonian crisis, we are in fact knocking out the cortex. How does this happen? Well, it can happen stress, infection, steroid withdrawal, autoimmune diseases. The most common cause worldwide is what? It is in fact infection. Infection. For Addisonian crisis or adrenal crisis, it is in fact infection. What infection globally is going to be the most common cause in this situation? It is in fact tuberculosis. Tuberculosis. But there are so many different ways that this can happen. And another one that's very common. So infection, we talked about tuberculosis, autoimmune diseases, stress, abrupt steroid withdrawal. So if somebody is given a steroid for whatever inflammatory process, how do we typically prescribe it? How do we give it to them if it's an acute situation or it's a dose situation? We're going to taper the dose. We give it to them in a dose pack. So it'll be like 7, 6, 5, 4, 3, 2, 1. We taper them off. And we give it to them in a pack just like that, because do we trust our patients? Not so much. Not so much. So in this situation, because of what can happen, the severity of the side effect of abruptly stopping a steroid. Oh, I feel better. I don't need to take it. No, 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 no. You're going to taper off. That's why we've given you a dose pack. So what are we worried about? Well, the 5 S's: sudden pain, abdomen, back, legs, syncope, severe vomiting, diarrhea, hypovolemia, hyponatremia, hyperkalemia, because remember that aldosterone. Go back to that whole RAAS. If you don't know that lecture, you definitely need to watch it. We knock out aldosterone, we lower sodium, blood pressure goes down. If sodium goes down, potassium goes up. So if I'm getting rid of sodium, water follows it. I become hypovolemic. I get low blood pressure. I get high potassium, hyperkalemia, hyponatremia. And then we're knocking out that cortisol, that middle part of the cortex. So again, we got that low blood sugar because we're knocking out the cortisol as well too. So again, signs and symptoms. So again, what are we going to do? Give them what they don't have. Give them steroids. They're not making cortisol. Give them fluids. They're not retaining anything with normal saline. We don't need to add salt in this situation. Normal saline will be just fine. And then watch their electrolytes, because again, that hyperkalemia, hyponatremia, and our glucose levels, we're worried about them because the sodium potassium can cause dysrhythmias, especially the potassium. Ask Graph, right? Low or high potassium can cause dysrhythmias. And what is the most deadliest dysrhythmia? And now we go right into, we're in endocrine. And look at what we're talking about: fluids and electrolyte. We're talking about steroids. We're talking about dysrhythmias. We're talking about Ask Graph. Do you see how everything ties together? If you put all this together, you're going to be just fine on the boards. And then vasopressors if the blood pressure remains low. So ventricular fibrillation, exactly. Now take it one step further with ventricular fibrillation. Do we do synchronized or unsynchronized? Cardioversion. Take it one step further, unsynchronized. Why? See, do you notice I keep going with that? Why? Why? What do we not have? No R wave. Those of you that have been my EKG lecture, there you go. You see how we come right back to it? Little quick tip: if you want to take a picture, go ahead and take a picture. I will allow it because we are going to post it. So a nice little breakdown between thyroid storm and Addisonian crisis. So cool little quick tip made by our team. Now let's get into a wonderful bow tie. So a nurse is caring for a 45-year-old female patient, emergency department, who was brought by EMS after being found unresponsive at home. Patient has a history of hypothyroidism. Clue number 1, recently discharged from the hospital for pneumonia, infection, but reports not taking her medications for the past 2 weeks due to financial difficulties. What medications are we concerned about in this situation? I'll take 2. Maybe, okay, I'll take 3. I'll take 3. Maybe for pneumonia, I would take steroids depending on the severity of it, but maybe antibiotics. But more importantly, thyroid medication. Yeah, thyroid medication, right? So I would take 3 different types. This one's a very stretch because we don't know the severity of it, but pneumonia, antibiotics, thyroid, for sure. Patient family states that she's been lethargic, confused, extremely cold to touch, unresponsive to verbal stimuli, shallow respirations, cold and dry skin. So now we got signs and symptoms. Of the signs and symptoms, what are the ones that stick out to you? Well, lethargic, confused, cold to touch. shallow respirations, cold, dry skin. What is happening to this patient that has a history of hypothyroidism that is unfortunately non-compliant? Not that they're trying to be non-compliant, but due to financial status, they're unable to purchase their medications. It is, in fact, myxedema coma. Good. So now that we've understood that it's myxedema coma, what are some differential diagnoses that we could potentially throw in there? I would take that, okay. I would take hypoglycemia. I would take mental decline. I would take, okay, good. So you see, we're starting to formulate what other things could be there as well too, but now we've got a few extra details here. So again, our nurse's notes show general appearance, unresponsive cold to touch, delayed capillary refill, so that warm red oxygenated blood is not getting there, swelling of the face, periorbital edema, confirming our initial thoughts of myxedema coma, dry, rough texture, thinning eyebrows, cool to touch, okay, still right along the same lines, heart rate 45, severely bradycardic, hypotensive 82/50, weak peripheral pulses, respiratory rate at 8. Where should we be at? We should be at 12. Good. We should be above 12, 12 to 20. So now we've got O2 of 88% on room air, non-responsive, people sluggish but reactive, and again, no bowel movement. So again, going right along that lines of severe hypothyroidism, which is in fact myxedema coma. Now we're looking at our lab values. Whoa, my TSH, my thyroid stimulating hormone, which means where is this produced? Where is this produced? Pituitary gland, in the pituitary gland, which means that my thyroid in severe hypothyroidism is not making my thyroid hormone, my T3 and my T4. And typically you're going to see T4, free T4 being measured, but now we do a whole thyroid workup, a whole thyroid panel, and you'll get your free T3, free T4 as well too, but free T4 is severely low because my thyroid is not making the hormone, because this person doesn't have their medication and their thyroid is clearly not functioning properly, which is why they were on medication. And now their T4 drops, which means that my brain thinks I need to make more. So my thyroid stimulating hormone is going to overact to try to stimulate my thyroid. But is my thyroid working? Is it going to respond to the thyroid stimulating hormone? It's not. My thyroid is just not functioning. So now my blood glucose has dropped. My respiratory rate has dropped. I'm having severe hypothyroidism. So if my respiratory rate is, now let's go into now look at this. Now we're going to go into a little bit of respiratory. So now if my respiratory rate is at 8, what am I not breathing off? I'm not breathing off CO2, which means is my CO2 level potentially going to be high? Respiratory, right? If I can't breathe it off, my CO2 levels are going to increase because I can't breathe it off. So I'm retaining CO2. So we see that. Is CO2 acidic or basic? Now look, now we're going into renal with ABGs. We're in endocrine. Do you see how it all comes together? It is acidic. CO2 is acidic, which means what is my ABG pH going to be? It's going to be acidotic. Yeah, absolutely. It is. And now, is my bicarb basic or is it acidic? Is it alkalotic or is it acidic? It is basic. Bicarb is basic. It is alkalotic. So because of the fact that I am in an acidotic state, my bicarb is low. This is in fact metabolic acidosis with respiratory acidosis. sorry, respiratory acidosis with metabolic compensation. So this is one of those harder ones, but ultimately we're able to see that we are in fact having acidosis. Our sodium levels are low, our potassium levels are a little bit high. So yes, respiratory acidosis, because again, our respiratory rate is 8, right? So now, when we do a bow tie, where do we start? In the middle. Of the 5 types of questions, what is this type of a question in the bow tie? What is the middle part? It is, in fact, it is a diagnostic question, which is which one of the 5 types of questions? It is a freebie question. Either you know this or you don't. Is this HHS? No. Myxedema coma, we lean towards that, but have I decided yet? No. Adrenal crises? No, because why? This patient has a history of hypothyroidism, right? History of hypothyroidism. Thyroid storm would be the opposite. Good. So we are in fact sticking with myxedema coma. Now, this is the freebie portion of it. So it is one of the 5 types of questions. Now we move to the left and we see what we're going to do. Action to take. What is action to take? What type of a question are we doing here? Select all that apply by way of education. This is just select all that apply. I just know how many I'm going to select. I'm going to select 2, right? It's that simple. It's a select all that apply question. And it's education. What type of a question is this? Same thing. Select all that apply. I'm just choosing 2. And it is education. What am I going to monitor? Well, I better be educated on that. So you see, the 5 types of questions still apply to NextGen. There's only a finite amount of ways I can ask a question. Can I make it look differently? Yeah, absolutely. Absolutely. Interventions, education, interchangeable. Test taking strategies. Understanding it changes your approach. Select all the apply, educate. What am I going to educate this patient on? Am I going to administer insulin and dextrose? They're severely hypoglycemic. Why would I give them insulin and drop their blood sugar even more? I can automatically eliminate that one. How about that passive warming? Yeah, I do like that passive warming. Notice I still started from the bottom. I'm still using the method. Am I going to give them methimazole? No. Why? Again, I'm going to ask why. Here's some pharm. Y'all ask me about pharm all the time. Here's some pharm. What is methimazole used for? Hyperthyroidism. Good. What's the other drug we can start a patient off with for hyperthyroidism? PTU, propylthiouracil. Propylthiouracil or PTU. Yes, propylthiouracil, methimazole are used for hyperthyroidism. So notice, if I'm talking about severe hypothyroidism, I'm going to try to confuse you with the medication that deals with hyper. It's just what us test makers do. PTU first trimester, good job. Which automatically leaves me with what? Levothyroxine. Because again, give them what they don't have. So yes, I would agree with you. And 1 and 3. Now, I go over to the right side. So what am I going to monitor for this patient? Am I going to worry about hyperthermia? No, because again, we're dealing with the opposite. How about respiratory depression and CO2 retention? Well, yeah, airway. Their O2 sats were what? 88%. The respiratory rate was 8. So yeah, 100%. How about monitor for hypotension and need for vasopressors? Yeah, why are we worried about that? Well, it was 82/50, I think, if I'm not mistaken. I'm not going to scroll back up, but it was somewhere around there. 82/50, and their heart rate was what? It was 45, 42, 45, something. It was low, in the 40s, right? So yeah, absolutely, I'm going to hold on to that. Have I made a final decision yet? No, because I am going to, in fact, look at 1. And monitor for seizures due to hyperglycemia. Well, no, again, I'm changing up the word minutely just so I can see if you're paying attention. So now we're looking at keeping 2 and 3. How are we feeling about application of the knowledge we learned about with myxedema coma, severe hypothyroidism? So again, diagnostic, education, education. And again, look at how much other stuff we tied in. EKGs, ABGs, LMNOPs. No, I'm just kidding. But QRSTs for sure. So yeah, we could, I mean, think about all the things we did tie in, right? Potassium levels, aldosterone, endocrine, everything all comes together. That warm, red, oxygenated blood from cardio all comes right back. It comes right back. All right. Now we've taken the same thing and we've turned it. Be safe, be safe. Those that are in Hawaii, it looks like big storm. So we've now converted this into a case study because ultimately we can take all of these and turn it into a case study. So we're dealing with the same, essentially the same patient. So again, found unresponsive, hypothyroidism, same patient. I'm not going to go through it. Heart rate still low, blood pressure same, respiratory, everything is all the same. Okay. So, or close to it. I'm basically giving the same exact patient, just a little bit, maybe there's a little bit of fluctuation just because when we use these for our Q bank and they show up later, I want to make sure they're not the exact same. So we've changed up a few things, but ultimately it is the same thing. And 1 second, let me do this real quick. Sorry about this. I don't know why I did that. It froze. So again, we've converted this into, in fact, a case study, same patient. So now the first thing that we've got here is a select all that apply question. Which 3 findings require immediate follow-up? Well, it's a select all that apply, but what other type of question did I combine it with? I combined it with prioritization. Yeah, what we're freaking out about. So I've taken prioritization and turned it into a select all that apply. It is an ask graph, 100%. So let's find ask graph. And in this situation, I'm in fact telling you how many to find. Now, just to kind of give you a heads up, I'm giving you a select all that apply, but I could in fact turn this into an entire paragraph and make this into what type of a question for next gen. I could make this a highlighting question as well too. A little trick that Nurse Brittany has discovered, a little test taking strategy. When you go through, start highlighting on your test each answer choice up to however many you can, but start from the top so you can see them and then go through each one from the top down. From the top down. In this situation, you're reading in order, so you're going to read top down. But this is select all that apply, so we're still going to start with our heart rate of 42 from the bottom. Heart rate of 42, are we concerned about that? Is that something we're freaking out about? Yeah, absolutely. Because what is this leading to? If my heart rate is that low, what is this going to lead to of ask graph? I will take 2 here. I will take airway. I will also take, if I'm not perfusing, alternate mental status. Good. So I've got 2 of ask graph here. Okay. Blood glucose of 58. Well, which one is this? Glucose. TSH of 13.5. Are we freaking out about that? No, it's expected, right? It's expected. It's our pituitary gland's way of responding to our thyroid not making thyroid hormone and us not having the supplementation of thyroid hormone orally. Respiratory rate of 8. Yes. Why? It is, in fact, another one of Ask Graph. Well, I found 3. So you got to convince me out of these 3, because I found 3 of Ask Graph, because I'm looking for that first initial priority, urgent, most concerning, immediate report to HCP. I found 3 of Ask Graph. So constipation, is that going to negate any of these 3? No, absolutely not. So I'll get rid of that. And a sodium level of 129. No. Because again, sodium levels of 129 are not going to lead us to seizure. It's when we get severely hyponatremic that we get concerned. So you see, we are in fact using Ask Graph and the method, and you've got to convince me out of these 3. And you can't. You can't. 129, what's normal sodium levels? 135 to 145? Is that really going to cause a seizure? No. But my heart rate's going to cause airway and altered mental status. My glucose, my body's shutting down. I'm going into a coma. Mixed edema coma. We already talked about this being the same patient. And the operative word here is coma. And then respiratory rate, well, that is clearly airway. So again, very, very important. If you don't know Ask Graph for prioritization, then make sure we do have group studies this Friday or Thursday. Where's Brittany? Is it Friday or Thursday?
13th and 16th.
So tomorrow?
Yeah.
Put a link in there for those that don't know Ask Graph and prioritization. Brand new practice questions, even a highlighting type of a question just like this, where we're going to do a case study highlighting question for Ask Graph. And it's 90 minutes with me breaking Ask Graph, prioritization, brand new questions, case study with highlighting, showing exactly this type of question. It's $29.99. It's a steal, in my opinion. The company lowered the prices on a lot of them. So again, it's there if you want to join for $29.99. So it's going to be me breaking down Ask Graph Ash as well with brand new practice questions, nothing you've ever seen before anywhere. It's $39.99. Sorry, I may have said it incorrectly. Whatever the link says. So I apologize. And they'll let you know all the details. I think $39.99 is the maternity one, because that's 3 hours on Sunday. 3 hours on Sunday with myself and Nurse Brittany. Cool. So again, Ask Graph with select all that apply, and there you go. All right. Well. We made a case study, and lo and behold, what do we have in front of us? We have a matrix and grid, right? What is this? This is in fact still a select all that apply. Because what am I asking? What am I asking for? And if you look, signs and symptoms. Signs and symptoms. And now we're going to go column by column, because again, I want to keep my horse blinders on and I want to stay focused on what I know. Mixed edema coma, severely hypothyroidism, severe hypothyroidism. Are we going to have hypothermia? Yeah. Is my heart rate going to be severely low? Yeah. Is my blood pressure going to be low? Yes. Am I going to be hyperthermic? No. Tachycardic? No. I've just said the opposite. Respiratory depression? Yes. And hypoglycemic? Yes. Because I know mixed edema coma. I know the signs and symptoms. I know my content. It's simple, which means that they're going to ask me other endocrinology emergencies, endocrinology endocrinological tongue twister right there. Woo! Endocrine. Now I can't even say any of it. Emergencies in endocrine. Woo! Wow, it's been a long day, let me tell you. So we've got more emergencies in endocrine. Woo! Tired. So now we got thyroid storm. So with thyroid storm, are we hypothermic? Endocrinological emergency. Sorry, it was bugging me now. All right, so now we've got in thyroid storm, hypothermia. No, right? In thyroid storm, everything is hyper. So are we bradycardic? No. Are we hypotensive? No. Are we hyperthermic with thyroid storm? Absolutely. Are we severely tachycardic with thyroid storm? Yes. Are we going to have a respiratory system that's depressed, or are we going to be tachypnic in this situation? Tachypnic, right? And hypoglycemic? No. And then now we're going to talk about adrenal crises, which was the last one I talked about, which is Addisonian crisis. In this situation, are we going to be hypothermic? Hypothermic? Okay, I'm going to go with the majority. And then, because this is always a learning experience, are we going to bradycardic in adrenal crises? Remember, I'm knocking out aldosterone. I'm knocking out cortisol, and then the sex hormones, which we're not really going to get into too much. So bradycardic, are we going to be bradycardic? Okay, I'm going with the majority. Are we going to be hypotensive? Okay. Are we going to be hyperthermic? Well, you can't say yes to hyperthermic because, well, you chose hypo, right? Tachycardic? No, because you chose bradycardic. Okay. Respiratory depression? Okay, I'm going to have to go back and review adrenal crises with everyone. Am I going to be hypoglycemic? Okay. So again, we're talking about adrenal crisis, and I'm going to go through this again because I think I might have gone through it a little bit too fast. So I'm going to cover this, but let's see how we did. Okay. So I went with the majority, which means if you're amongst the majority, this is what has happened. Let me get a different color here. So I went with the majority, and I'll go through adrenal crisis a little bit more because apparently I didn't do my job to explain it correctly. So with adrenal crises, okay, first things first, I'm gonna take a step back. We missed 3. Okay, collectively, majority. If you didn't, good for you. Again, I went with the majority. Let's just say that this was our situation. This was my situation on the boards. Well, I've got 1, 2, 3, 4, 5, 6, 7 times 3, 21. Correct? I got 21 options here. 7 plus 7 plus 7. Everyone with me? I've got 21 options in this one matrix or grid. I missed 3, which means I've got 18 correct because I do get partial credit. Somebody do the math for me. What percentage is that? 85%? I missed 3. It sounds bad. Is it? If you're getting 85%, you're passing. If you're getting 85%, what do I tell my students on your QBank? What percentage do I want you to be in? 75 to 85%. Yeah, I'd like you hovering around the 80s. This is right above that. So the point is that don't dwell. Don't dwell on if you missed it or not. Do the ones you know and then go with an educated guess. Well, with the adrenals, does it have anything to do with body temperature regulation? No, I said aldosterone, cortisol, and sex hormones, right? I'm talking about the adrenals, not the thyroid. The adrenals. Do the adrenals affect my heart rate? The adrenals don't affect my heart rate. They can affect my blood pressure. Now let's think about that. Why? In blood pressure, I've got aldosterone, which controls sodium in water, blood pressure, cortisol, blood pressure, right? So blood pressure can be affected. If I have no aldosterone, no cortisol, I do become hypotensive. But heart rate is not affected. Temperature is not regulated. Blood pressure because of aldosterone, sodium in water, and cortisol. Blood pressure, a big fib. Remember that, right? Remember that mnemonic from Endocrine. So if temperature is not regulated by the adrenals, okay, again, heart rate is not regulated. I get rid of that. Respiratory rate is not regulated. But sugar is because of what? What part of the adrenals? I said aldosterone, cortisol, sex hormones. So which one of the three in the adrenals is affected? Sugar, cortisol. And if I knock out the adrenals, I'm decreasing aldosterone, I'm decreasing cortisol, becoming hypoglycemic. Tough concept. I'm going to leave this up on YouTube. Once I take out my fumble of endocrinological emergencies, I'm going to edit that out so nobody can make fun of me. You caught it here live. I am human. So with that said, I will put that up there so you can go back and watch it, because the adrenals are very important, as you've seen. We've had other students say, look, endocrine is showing up a lot on the boards, which is why we did this. So, all right. Drop down is a freebie question. Either you know it or you don't. Either you know it or you don't, right? So you're at risk for developing, give me a diagnosis. Is it a thyroid storm with mixed edema coma? No. Respiratory failure? I'm going to hold on to that. DKA? No. Due to, give me a cause, freebie question. Ketone buildup? Well, that's probably DKA. Increased metabolism? That's probably thyroid storm. Or CO2 retention? CO2 retention. Again, I'm severely decreased in my thyroid hormone. I'm hypo in everything. Respiratory rate drops. I retain my CO2, leading to respiratory failure. Straightforward, freebie question. How are we doing on time? Cool. All right. Intervention is expected or unexpected. What is another word for intervention? Education. This is, in fact, select all that apply by way of education. Nothing has changed here. Am I going to educate to give this patient levothyroxine? Yeah, give them what they don't have. If they're cold, should I passively warm them? Give them what they don't have. Methimazole. Well, we talked about this in Farm in the bow tie with what? Hyperthyroidism. Rapid rewarming. No, we don't want to send them into shock. That vasodilation, right? So no. Intubation for respiratory failure. They're unresponsive. The respiratory rate is 8. Do you think I'm already probably intubating them at this point? I probably already have at this point intubated them, right? So yeah. And if not, then I sure better be prepared to do it. And there you go. So at this point, we did, now do the math. Somebody do the math for me. We got 3 out of 6 right. So that was 6 questions. We got all 6 right. Then we did the matrix grid. We got 18 out of that right. So we got 6, 27. Then we did another 1, 20 or 2, 27, 29, another 1, 2, 3, 4, 5, 30, 1, 2, 3, 4, 5. So 34. We've got 31 out of 34. Somebody do the math for me. We got 31 out of 34 correct. What's our percentage? We've got to be in the 90s. 91. Do you see how that one question really didn't make a difference? We're scoring 91% so far. Are you passing? You better believe it. You better believe it. Confidence, confidence, confidence. All right, immediate follow-up. So what type of a question is this? It is, in fact, prioritization. We're looking for ask graph. So now I'm going to use a method. Constipated for a few days, or chest is really tight, hard time breathing. C over D. Good. Those of you that say C over D, excellent way of using the method, because this is, in fact, which one to ask graph. Airway, airway, airway. Now you got to convince me out of that one. I'm feeling really sleepy and don't want to eat anything, or airway. C over B. Excellent way of, again, using the method. I'm down to 50-50. I'm sitting pretty. I feel really cold, even with all these blankets. Okay, I'll give you some more. Airway, airway, airway. I am now 32 of 35. Prioritization question. And the last one in the case study. So which of the findings indicate whether we're improving or no change? So improvement or no change, and my pencil stopped working. So since this is the last question, I'm just not going to mark it, but we'll go through it together. So with a heart rate of 70, are we improved from our heart rate in the 40s? Yes. Our blood pressure is 86 over 52. What were we at? Anybody remember? Let me go back up here. I feel like it's really not a big change. 82 over 50. So are we really improving in that situation? Not so much. Not so much, right? O2 went from 88 to 95. Temperature, 96. No, I don't remember what the temperature was, but if anybody remembers, no change. Okay. And then respiratory rate, still between 8 and 10. No change, right? So I think the majority of us got this right. So improved, no improvement, 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 no improvement. Good. So ultimately, we went from, we said 32 out of 35. So we went 32 out of 35, and then we got another 5 right. So 32 out of 35. So 37 out of 40. What's the math on that? 37 out of 40. %. That's between, and then if you got the bow tie correct, which we all did, add in another 1, 2, 3, 4, 5 points out of 5 out of 5. So 45, 42 out of 40, or what did we say? We said 42. So 42 out of 45. What's 42 out of 45? Add in the bow tie. 93%. So you just did a bow tie and a case study, and you're scoring at 93% on a very tough subject, by the way, because we still did miss 3 because we didn't have a complete comprehension of Addisonian crisis, which is my fault. I take blame for that. That's my bad. Which is why I'm going to leave this video up, and maybe I'll do something as a podcast or something like that to include that. So maybe I'll just do a podcast on that, so that way y'all can listen to it. So how are we feeling? Brand new lecture, right? Stay safe, by the way. Stay safe out there in Hawaii. How are we feeling? Good. We should feel confident. Those of you that are getting ready to take your exam, best of luck on your exam. Remember, stay positive. And again, the course is coming up. Group study tomorrow. If you don't have it, the link is in there. We've got trivia today as well too. Again, as usual, I thank all of you for joining me. If I made any mistakes, I apologize. If I offended anybody, I apologize. And if I can get better in any way, please yell at me, yell at my staff, let them know how I can get better, and I will try to get better throughout this process. Those of you that are going to the nursing convention, I will see you there in April as well too. I'll see you next week for sure. Next week's subject is GI disorders decoded. GI disorders decoded. We're going to go through GI disorders, super high yield as well too. So we're going to make it fun. Tomorrow, endocrine, maternity on Sunday, 3 hours of maternity, antepartum, labor and delivery, postpartum, and newborn. So huge, huge, huge topic. 3 hours with me and Nurse Brittany. You've got trivia coming up. Good luck to y'all with trivia. And again, all I ask is you spread the word. Just spread the word. And that's all we ask in return. So we can keep doing this. So everyone, thank you again for joining. And I will see you all later. Nurse Brittany, you ready? I'm going to put you as host. Nurse Crystal, thank you for joining me. Our team, Jess, Rose, and Melissa, thank you so much for helping out as well too. Y'all are awesome. Cool. All right. I am out. Take care.
Thank you, Dr. Z.
Thank you.
I'm gonna fix the pin for you guys, okay? And you guys can join in. We usually start around 7:10 Eastern time. So I'll give you guys about 10 minutes, 9 minutes to join in, okay? Okay, we're going to get started. Sorry, guys, I can never figure out how to get the bar to pop up to unmute myself. Okay, so let's go over. Which one was the one I wanted to go over? Oh, this one. Which medication is contraindicated in a patient with a sulfa allergy? Um, so I would go with furosemide, but let's go through all of them. So warfarin. Warfarin is an anticoagulant, right? It doesn't contain any sulfa derivatives. So I wouldn't go with that. Metoprolol is a beta blocker. That's not related to sulfa allergies. Aspirin is an NSAID, also doesn't contain sulfa. It can trigger reactions in patients that are sensitive to aspirin. Um, but I wouldn't go with that either. Furosemide or Lasix, that's a loop diuretic that does contain sulfonamide, a sulfonamide component, which could trigger an allergic reaction in patients with sulfa allergies. Does that make sense to everyone? Any questions there? Okay. No hold on. I don't have the chat pulled up. I can't even, it's not popping up for some reason. Why can I see the chat? Because someone writes something in the chat. I just want to make sure it's working for me. I don't see it popping up here. Oh, here we go. Sorry, guys. The laptop version of Zoom gets me sometimes. Okay, there we go. Hi, everyone. Okay, so let's see. What is the most critical intervention for a patient with a suspected fat embolism? Give IV heparin. No. So IV heparin is used for blood clots. But it's not going to be effective for fat embolism. Does that make sense? Place in Trendelenburg, that's contraindicated. That can worsen respiratory distress in this person because it's going to increase venous return to the lungs. So I wouldn't go with that. Apply high flow oxygen. Why do we like this answer? Because that's going to treat hypoxia, right? And prevent respiratory failure. So fat embolism can cause ARDS, acute respiratory distress syndrome. It can cause tachypnea, hypoxemia. So oxygen administration is going to be pretty priority. And then administer aspirin. Aspirin's not useful in treating fat embolism because it's not going to prevent or dissolve the fat globules. Does that make sense to everyone? Any questions on that? So an air embolism is when air enters the bloodstream. It could be from a central line, usually most of the time a central line. Fat embolism is when fat globules enter circulation. So it could be from long bone fractures, for example. The onset of an air embolism is sudden and it's quick. The onset of a fat embolism is slow, like over like 24 to 72 hours. Does that make sense? You're welcome. Okay. Can everyone still see the screen? Because I'm very confused. It just slid off of my screen and I can't seem to find it. We are frozen. Okay, I don't know where it went. Holy cow. It literally just like slid to the right off of my screen. I don't know where it slid to. Geez. Oh, okay. There we go. I don't know what I did, but there we go. Okay. Any questions here? Can everyone see the screen again? Any questions with this one? Everyone okay here? Okay, so let's go over it then. Which interventions are appropriate for a patient with increased ICP? So administer mannitol. Yes, I would go with that. That's an osmotic diuretic. That's going to help to reduce cerebral edema by pulling that fluid out of the brain tissue and lowering ICP. Cluster care, no. If you cluster your care, you're going to stimulate them too much. You're doing too many things in a short period. That's going to increase their ICP. Instead, you want your interventions or whatever you're doing with them spaced out to let their brain recover. Maintain neutral, let me see. You're welcome. Maintain neutral head position. Yeah, you want to keep that head midline and avoid any excessive neck flexion or any rotation. Raising the head of the bed 30 degrees. So yeah, elevating the head of the bed to 30 degrees is going to help promote venous drainage from the brain. Does that make sense to everyone? Please tell me if I'm not doing a good job at explaining, because I want to make sure you guys understand why the right answers are right, why the wrong answers are wrong whenever we're going over questions. And that's what you guys should be doing when you're doing questions on your own as well. Awesome. Okay, good, good, good. I tend to try to go over the questions where I see there's a lot of confusion in the answers or a lot of people got them wrong, okay? So that's why I'm not going through every single one, because then we might be here all night. Okay, so let's go over this one as well. Which finding requires immediate intervention in a patient with SIADH? Okay, so let's see. Sodium of 145. Yes or no? So again, which finding requires immediate intervention in a patient with SIADH? So which one are we freaking out about in a patient with SIADH? A sodium level of 145. Normal is 135 to 145. So in SIADH, hyponatremia is a big concern, not hypernatremia. Seizures, yes. I'm freaking out about that. So SIADH leads to severe hyponatremia, which can cause, altered mental status, cerebral edema, seizures, because of that fluid shifting so quickly into the brain cells. Blood pressure of 140 over 90. Mild hypertension isn't the most critical, I'd say, in SIADH, unless it's like super severe or it just keeps getting worse. That's a different story, but I'm not freaking out about that here. Urine output of 200 milliliters per hour. So in SIADH, urine output is typically low, like less than 20 milliliters per hour, and it's concentrated because of the excess ADH. So increased urine output might tell us there's some improvement, not anything critical. Does that make sense to everyone? Any questions there? So in SIADH, that water retention plus that dilutional hyponatremia puts them at a risk for seizures. You want to make sure you're watching them for neuro changes. altered mental status, confusion, headache, seizures. And you'll treat severe hyponatremia with what? Hypertonic saline, all right? Hypertonic is salty, 3% sodium chloride, but you'll do that slowly. Also, you're going to want to restrict fluids, right? Can high sodium lead to seizures? Yeah, both high sodium and low sodium can lead to seizures because the fluid shifts again affect the brain cells. Okay, so let's move along. Tell me if I talk too much, guys. Okay, let's go over this one too. Which interventions help prevent ventilator-associated pneumonia? Which interventions, and this is a SATA question, help prevent ventilator-associated pneumonia? So suctioning every hour routinely. So we're looking at what is preventing VAP. Suctioning every hour. Suctioning should only be performed as needed. Exactly, Tanzine. Yeah, as needed. If we're doing it routine and we're doing it frequently, that can just cause damage. That can increase their infection risk. That could just lead to trauma to their airway. So I would get rid of that one. Daily sedation vacation. What is a sedation vacation? Who can tell me what that is? What is a sedation vacation? Basically, you temporarily stop the sedative medications in mechanically ventilated patients, just so we can assess their neurostatus and how ready they are for us to wean them off the ventilator. So it's just going to prevent like prolonged mechanical ventilation. It also reduces the risk of VAP. And it just lets us assess the patient, their breathing, their spontaneous breathing, and just their neurofunction. Makes sense? It actually helps improve survival rates in our patients. So it's called a sedation vacation. So it's just like a daily sedation interruption per se. Make sense? So daily sedation vacation, I would go with. That's going to, again, help us to assess their readiness for extubation. Make sense? Head of bed elevated over 30 degrees. Yes, that prevents aspiration of those secretions into the lungs. That's definitely a key factor in VAP prevention. So we're going to want to make sure we keep that head of the bed like 30 to 45 degrees. Unless it's contraindicated, that's another story, but it should be 30 to 45 degrees. Oral care every 2 hours. I would say yes, that's going to reduce bacteria in the mouth and the oropharynx. That's also going to decrease the risk of aspiration pneumonia. Exactly, Tanzania. Does that make sense? So VAP is a serious complication of mechanical ventilation. So we definitely want to take preventative measures and focus on reducing that aspiration risk, that bacteria from growing, improving their lung function. Makes sense to everyone? Everyone got that? So you want to make sure you're doing oral care, right, with chlorhexidine, usually every like 2 to 4 hours. We said make sure that head of the bed is elevated. I'd say like 30 to 45 degrees. Sedation vacation is important, right? Spontaneous breathing trials. These are important things for getting them off, weaning them off. What else? What else? What else? Hand hygiene is always important as well, right? Aseptic suctioning technique. So VAP is a preventable complication, right? So just early extubation and just controlling any infection, those are going to be key. Make sense to everyone? Okay, let's go over this one too. So, what are early signs of hypoxia? This is a STATA question. Restlessness, yes or no? Yeah, restlessness is an early sign. That's an early indicator that the brain's not receiving enough oxygen. So, yeah. Anxiety, yes or no? Yeah, I'd say that's another early sign because basically that patient's experiencing um a sense of impending doom because of that low oxygen supply to the brain. Tachycardia, yeah, the body increases the heart rate to compensate for those low oxygen levels, right? I'd say again, that's an early sign. Tachycardia, restlessness, anxiety, agitation, confusion, pale skin, those are all early signs. Cyanosis, no. Cyanosis would be a late sign. If their skin is turning blue, that's a late sign. Because that's what you're going to see after prolonged hypoxia, right? When those oxygen levels are pretty low for too long. So that'd be a late sign. Cyanosis, bradycardia would be a late sign. Um, Hypotension, coma would be a late sign, right? Does that make sense? So there's a mnemonic that I have for early versus late signs. And I'm going to write it in the chat. Rat bed. So rat are your early signs. Bed are your late signs. So write this down. So rat is restlessness, anxiety, tachycardia, or tachypnea. Those are your early signs. Your late signs, bed. B is for bradycardia. E is for extreme confusion. D is for dyspnea and cyanosis. Everyone got that? Hopefully that's helpful for you guys. Okay, let's go over this one together. So what is the priority intervention? A patient with SIADH has a sodium level of 120. What is the priority intervention? So let's go through all our answers together. Encourage fluids. Yes or no? No. SIADH patients should have fluid restriction, right? If you encourage fluids, that's going to worsen it. Administer furosemide, Lasix. That's only used if sodium is over 125 to help them diurese. Make sense? And in severe cases, hypertonic saline is going to be preferred first. Exactly. IV fluids. Hypotonic fluids are going to worsen SIADH. They're going to dilute sodium even further. Does that make sense? For severe cases, we're going to give hypertonic saline at 3% sodium chloride. And remember, we have to infuse it slowly, or then we're going to cause CPM syndrome. Seizure precautions. Yeah, you want to put that patient on seizure precautions, padded rails, oxygen, suction at the bedside. Watch for any confusion, lethargy, if they're twitching. Those are signs of worsening hyponatremia. Does that make sense? So when someone has severe hyponatremia, like less than 120 usually, that increases their risk of seizures because of cerebral edema. So priority is going to be seizure precautions. Makes sense? So sodium less than 120, seizure precautions first. Also with SIADH, fluid restriction, right? Like 500 to 1,000 milliliters per day. Hypertonic saline, 3% for severe cases. Make sure you give it slow, like we mentioned a few times. And you want to watch these patients for any neuro changes. Like we said, seizures, lethargy, confusion. We're freaking out about those things. Make sense? Okay, which ECG changes suggest pericarditis? Deep Q, this is just really memorization unless you're really good at the ECGs. But I remember for my exam, I had like a whole little cute chart I made. I don't remember where it is, but to help me remember these things because I was scared I was gonna get questions on this. And you don't need to know what it looks like, I'd say, just how to describe it. But yeah, I would go with ST elevation and all leads here. Let's go through all of them. So deep Q waves. Yes, because that's gonna be, I mean, I'm sorry, why am I saying yes? No, because that's gonna be this is honestly just I'm gonna try to find my I'm gonna try to find the chart that I made in my notes. I don't think it's super high yield to, did anyone get questions on this like this on their exams? No, yeah, I don't think it's super. I mean, you know it just in case, but deep Q waves, that's indicative of a prior MI. Prolonged PR, or let's go ST elevation in all leads. Yes. So with MI, you'll see localized ST elevation, but pericarditis is going to affect multiple leads. Does that make sense? Oh, he mentioned this. Yeah. So good. So then just know that the ST elevation all leads. Yeah. Pericarditis is important. So I would make sure you know that one. Um, Prolonged PR interval. Um, no, it would be with pericarditis, it would be PR depression. That would be classic with pericarditis. Widened QRS. Um, you would see that in like hyperkalemia, not pericarditis. Does that make sense? This is really just memorization. This stuff gets confusing, unless you're really, really good at ECGs. Make sense? Okay. Yeah, that one's a little tricky. That's just like you know it or you don't. So sorry, I was writing this in the chat, but I'm just gonna say it. With VTAC, what would some things on ECG be like? YQRS, right? Anything else? Yeah, wide QRS, yeah. The P waves are gonna be um they're gonna be absent. Yeah. That's really all that you need to know. Yeah, that's really all that you need to know. The T waves, that's not super important, but the T waves are gonna go opposite direction of QRS. Makes sense? Let's go over this question. So, Sada, what are signs of compartment syndrome? What are signs of compartment syndrome? Pulselessness. Yeah, if that's a late sign, the loss of distal pulses, that's a late finding. But yeah, pulselessness for sure is a sign of compartment syndrome. Once pulselessness happens, um, it's likely that now we're at like a place where we can't reverse this. Pulselessness is a late sign. Pulselessness is a late sign, the loss of distal pulses. Paresthesia, that tingling or numbness from nerve compression. That's usually an early sign. Severe pain unrelieved by opioids, that's an early sign. That's increased pressure within that compartment. Yeah. Decreased capillary refill, that may still be normal in early compartment syndrome. So capillary refill is not a reliable indicator for diagnosing compartment syndrome. Does that make sense? Make sure you know your 6 Ps of compartment syndrome, right? Pain, usually it's severe and it's unrelieved by opioids. Pallor, pale, cool skin. paresthesia, tingling, numbness, paralysis. That's a late sign, loss of movement, right? Yeah. Pulselessness, that's a very late sign. That's usually an emergency at that point. And then pressure, tight, swollen limb, right? We want to make sure we remove any constrictive dressings or casts, and we're going to most likely prepare for a fasciotomy, right? Sorry, guys. I don't know what I'm doing, but it keeps sliding off of the screen. Sorry about that. Stop, everyone. I just want to quickly go over a couple. Oh gosh, am I not able to go more? Okay, let me pull them up on my end then and go through them. Let's see, how do I get out of this? Oh, okay, cool. Let's go. I wrote them down. I wanted to go over 30 with you guys. Oh, wait. Hold on. Which one is number 30? Why is it? Oh, these were the difficult questions. So you guys did well on 30, I guess. That's confusing. Why is it out of order? Oh, here. Okay, let's go over 30. Um, oh, this one. Okay. So, which finding is most concerning in a patient with acute pancreatitis? So, hypocalcemia, elevated blood glucose, mild abdominal pain, tachycardia. I would go with the hypocalcemia. Um, I mean, yeah, I would go with hypocalcemia. Just trying to think. Let's go through the wrong one. So tachycardia, no. I mean, that could tell us, they're in pain. Maybe they're dehydrated. Um, Hypocalcemia is like a more direct marker of worsening pancreatitis. Um, Mild abdominal pain, that's expected. If it was severe or if it was worsening, like unrelieved by opioids, um, then I would maybe be concerned, but I'm not concerned here. Elevated blood glucose, um, no, that's not going to kill them right now compared to hypocalcemia. Hypocalcemia can lead to cardiac arrhythmias, seizures. That's more life-threatening. So you want to watch for signs of Trousseau's, Chubstacks, muscle cramps, seizures, right? So definitely hypocalcemia. Um, oh, where 35, I wanted to see. What is the priority intervention for a patient with a tension pneumothorax? Priority intervention. Yeah, definitely insert a chest tube. Um, that's going to be priority because that's going to relieve pressure in the pleural space. If a chest tube is not immediately available, they'll perform a needle thoracostomy. That's where they'll put a large bore needle at the second intercostal space, the midclavicular line. And that's going to release that trapped air. And then the other one was 40. What interventions are appropriate for a patient with pulmonary embolism? This was a SATA. So, wait, why don't I see? Were there only 3 options for this? How is it? Oh no, there were just 3 right answers. Why can't I see the incorrect? Okay. Let's see. So, okay, again, which interventions are appropriate for a patient with pulmonary embolism? You're welcome. Monitor for signs. There was another answer. What was the other answer? Something about okay, I'll think of it. Monitor for signs of bleeding. Yes. Because why? Anticoagulants increase bleeding risk, right? So you want to watch for like low H&H, hypotension, tachycardia, bruising. Administer anticoagulants. Yeah, heparin, enoxaparin, warfarin to prevent further clot formation. Administer oxygen. Yes, because pulmonary embolism leads to impaired gas exchange and hypoxia. So oxygen's gonna help, right? Um, was it Trendelenburg? Yeah, Trendelenburg. Okay, yes, Jennifer. That's what I thought. Not Trendelenburg. Trendelenburg would be contraindicated. That's going to increase venous return to the heart and maybe even worsen right heart strain and pulmonary embolism. So instead, the head of the bed should be elevated to help with breathing, right? Does that make sense? Okay, congratulations to our winners. If you won, please email contact@nclexhighyield.com so you can get your prizes. Everyone did an awesome job. I hope everyone enjoyed free Zoom today and free trivia. And we will be back as usual next Wednesday with more free content and another trivia. Okay. These aren't recorded for you unless you're in a live course, then they're placed in your portal. You're welcome. You guys are so welcome. And I hope to see everyone next week. Okay, have a fabulous day. Have a fabulous night. Have a fabulous rest of your week. If you're participating in the live course, I'll see you